Good morning, everyone. I'm delighted to be here. For people who don't know, you may know me. I've been involved as a Director of Operations at the area team for NHS England since its inception. So since January last year, I've been actually in the role down here, working with Jane Halpin. And recently, my colleague Beverly Flowers has actually got a secondment to one of your local CCGs, Eastern North Hart CCG. So I'm covering the commissioning role, and has been doing it, as Peter said, it's probably for 4 weeks now, actually. What I was really keen to do is to take the opportunity to speak to as many people as I can do as early on as you do when you start a role. So it was a great opportunity to come today and speak to as many practice managers. I am very committed to primary care, and from my biography that's in there, I've worked more recently in Leicestershire in various different roles. And clearly understand and see the important role that practice managers play in making things happen. And I think, as Peter explained there in terms of the beginning, the challenge that you have around juggling the balls. And I'm keen to have a conversation about how we can do that together, because maybe juggling them together would perhaps get us into a better place. So we'll see where that is. I'm not going to stand on the stage. The last time I was near a stage was at the weekend at Leicester City, its grounds, as they were promoted. So there was a whole number of people jumping up and down, and I was just at the side on the pitch, so I'm not going to do that. So I'll leave that to see how we get on next season. Briefly, in terms of what I want to speak to today, and it'll probably be sort of 20 minutes or so. And then Andrew is going to speak through CQRS, and we'll see then about open questions, discussions, abuse, compliments, however you want to play it. I'm more than happy to have those conversations. I have a key phrase, which is, we are where we are. I spent the first year of the transition in the new role saying, we are where we are, how do we move forward? And with my new team, it was interesting because Andrew just mentioned that without knowing the presentation. I think there's something just to recognise we're now a year in to the new system, so how do we move forward? And that's really what I want to focus my attention on. I do want to understand some of the issues about the history in the past, but it's about how do we make it better and how do we move forward, and that's my focus. So I want that to be, so you might hear me say we are where we are, but it is, the next bit is then how do we move forward? In terms of transition, again, you might have seen from the biography, the job is a major part of my life, but also in the last year, I've moved down to Hitchin, I've started a new role, and I've had my first baby boy, Jack, who was 1 last week. So when I had my appraisal last week with Jane Halpin, she did say, you've had a busy year. So in terms of transition and change, there are a lot of things, and it's how we sort of cope with that. He's sleeping 12, 13 hours at night, so we're in a good place. But he doesn't sleep at all in the day, so when I get home, my wife's beating on her legs. I just wanted to talk briefly about what NHS England commissioning were the responsibilities that we have, very, very briefly. Also then around the high-level objectives, and Peter's already touched on them, for primary care, and it's how we join in and make sense of that. Some of the progress and challenges. Very briefly on what we're doing locally across Hertfordshire and South Midlands. I want to have a discussion about how primary care plays within those conversations. And then the last two sections are more around some reflection on what that means for how we work, because the first section will mean that's a different approach and style, and that's very much about me individually, that's my team, and I would hope in terms of the conversation we have, that's about your own behaviour and how general practice responds. So there is a recognition that we do need to change the way that we work. Finally, some of the current challenges and opportunities, and then I'm again open to questions, and we'll have as much time as we can to do that. This is good, actually. Technically I can cope with this. In terms of just the broad areas, in terms of NHS England responsibility, as you know, CCGs have, it's 70% in terms of the total budget. We have responsibility for primary care, which includes GP, dentist, pharmacy, optometry. Also dental in terms of hospital, so some of the secondary care dental, some of the issues that we have there about waiting times. Public health, screening and immunisation programme. So within my team at Charterhouse in Welland Garden, We have some own public health staff, but also Public Health England staff. Some consultants are embedded within my team, so we have that responsibility. People may have picked up, there's some local and national noise around specialised services, and is it a mess that's in? The challenging position that's in, really, and that is part, again, of area team responsibility. 10 area teams lead on that. We're not one of them, but I think there's going to be quite a lot of change over the next few months. And our new Chief Exec, Simon Stevens, has already signalled that this needs to change. My sense is more will go to CCGs, and we'll work that through. And then finally, I'm not an expert in these areas, but armed forces and health and justice, and not all area teams do that. There's a number across the country that lead on certain areas. I won't take technical compliments for the map, but we are somewhere in the middle in terms of all the geography and the challenges that we have. There's 27 area teams. As I've talked about our overall responsibilities, we also have primary care support services. We deliver the national screening and immunisation programmes, and we're responsible for the Healthy Child 0 to 5 programme. So there's a broad range of commissioning responsibilities. My early sort of view of the role in sort of four weeks, the challenges and how varied it is really good, really stimulating. But it's important that we get a really clear view on what our priorities are as we work together. Otherwise, as we all know, it can be easy being very busy. But then when you step back, you think, was that a good use of everyone's time this week, during that day? So I'm really keen to get a view on what are the priorities we need to be working together on. Pete's already sort of touched on some of these areas, really. I'm not going to go through it, but I think these are objectives, principles that hopefully everyone in the room would agree and are supportive in terms of your own local populations, in terms of coordinating care, person-centred, good access, health promotion and high quality. There are a number of documents that come down from the centre about what this means and the strategies. What I'm really keen to do is to say, if they're the principles that we all agree about, what are we going to do about it locally in Hertfordshire and South Midlands? I spend my life, we could be influenced, distracted by everything that comes down. What I'm keen to do is, again, how do we move forward? Some of the principles, again, that I'm keen to develop further are with the whole system about CCGs. There was a real, their sort of benefit, their principles was around clinical decision making. It was about local populations. It was about health outcomes. And I think we need to go back to the basics of what the new system was meant to be, because again, I would hope that we would all be in a position when we would commit to those. And I think we've lost some of that in the last few months. That would be my sense. And we need to go back to the basics of that. We'll talk a bit about later, but in a lot of the planning guidance that's coming down, it talks about wider primary care at scale, and we need to understand what that means, and that could mean different things to different people in different areas, but it's clear that primary care in its current form needs to change. This was a slide that I found actually from a national session, and it's always useful just to see how, whether it doesn't feel like this on the ground, but how the linkages have been trying to be made nationally in terms of some of those different areas. So we'll talk more about our primary care strategy. I'll go on to that in a minute. In terms of empowering patients and in the area, there's a big focus around coordination of care, named GPs, the admission avoidance days. So that's all lined up in that direction around continuity of care for our patients. Back to the principles. There are other areas, some of which will be more contentious than others. We might want to have some conversation. An excellent presentation today about the Friends and Family Test, which is clearly linked to getting patient experience and views. Also about GP practices and the registering outside catchment areas, and what that will mean in practice was something we'll need to work through. And also around GP surgeries and the online services for booking appointments. So that's all about giving better patient access and giving them choice in the services that they can want to take on. As I've said, big view, personal view of mine, is about empowering clinicians. This is about clinicians making the decisions about their local population, and we need to do a lot more around that in terms of how we move forward. It's an issue around capacity. I understand people are very busy, but we've got to make sure that our doctors and other professionals are influencing what we do. The Challenge Fund, and I know a number of you potentially would have been involved in, we had a number of bids across the patch. One of ours has been successful because there was a massive demand that went up to the centre, and we've got one within Watford. So I think there's 9 practices in a Watford Care Alliance that are coming together to look at how they could deliver services, integration and care, end-of-life care, which is really exciting. But again, it's broadly what I think we're all trying to do in each of the different areas. So I'm keen to capture some of that learning, and also, if we can, use some of those existing proposals to move forward. Because I know there were some good proposals that were put forward in Luton, there were some good proposals put forward in Northamptonshire, which is further north of the patch, and it might be that we use that as a basis for how we move forward as opposed to starting again. So I'm keen to go back to that. In terms of investment and incentives, what I hear a lot of, as we all do, there isn't enough money in the system. We have, in terms of, there is a lot of money in the system, it's whether it's in the right area. And that's our role, to try and to look at how we commission. When I first started commissioning in Leicestershire, what was explained to me was the big challenge was, hospitals get all the money, how do we get the money into the community? And that is still the overall big commissioning challenge. My sense is we've got hospitals now that know they're not sustainable, it's not affordable in their current form, but how we make that switch with money is really difficult, but that is the challenge that we all have. What NHS England is trying to do is to make some little small steps towards that by, we're not supposed to say ring fencing, but I will do, in terms of specific money for primary care. So there's £5 per head, which if you look across our population is about 14-15 million, which is for CCGs and ourselves to work through and say what's the best way of spending that money. And also the DES, which I know is existing money, but there was a change around stopping doing a lot of other things around QOF, with the idea that this was more focused on patient care, reducing admissions, which hopefully then reduces the cost of patients going through the system. So it does all fit together. It probably doesn't feel like that on the ground. I think that's how we need to work it through. Some of the challenges that come with that, and I'm a very practical chap, and what gets me out of bed in the morning is knowing that things happen and you're making things happen, so I don't want to get lost in the bureaucracy. It's about what do we need to do and across each of the different areas, but there's some real key risks that we need to recognise and agree how we're going to move forward. I'll come on to this a bit later. Capacity. So the conversation, it's great to see as many people today, but actual having time in order to do some of the thinking about transformation. I've had conversation with GPs that say, yes, Dominic, we'd love to come, but we haven't got the time. We've got to try and break that cycle in some way so we can involve the right people in some of those discussions. Workforce, and we'll go on to some of the conversations we've had already with LMCs and Peter, is very quickly getting to a point in understanding what our position is locally. There is clearly a national issue, but I'm really keen, and I want to do it quickly, is understand where we are and then say what are we going to do and how do we influence some of that. I'm not coming with loads of new GPs behind me, but we do need to think about what different workforce we need to do, how do we need to influence the training, and it's not a short-term. It's not going to be a short-term win. It's got to be something that we do. We start now for looking ahead 5-10 years. Premises, and I'm sure people were going to mention that if I didn't. There is a real challenge again around money in the system to develop premises. I know there's been a lot of national interest and media around this in terms of premises aren't fit for what primary care needs to deliver. Again, it's part of that overall sort of discussion, isn't it, about how we can move some of that money around the system. It's always good to talk about a different area. I hope there may be no one here from Corby. But just to give some example in some of these areas, they're starting to look very seriously with local providers. So if I give the example with a local community and mental health provider, about who's a foundation trust, about how they could bring practices together and bring services of community and mental health together and build a new building in order to run those services. Now, that's not just about me sitting there on my premises pot, because it's not a particularly big pot for primary care, but the benefits come when this particular provider is getting off 10 different sites in the county and saving money as they do that. So they're coming then to the party with money and capital money, and we do need to think creatively in some of the areas. Now, we won't be able to do that everywhere across the patch, but in terms of areas of population growth and when we have got our biggest demands, I think there's something about how creatively we think about what the solutions are. And the wider primary care at scale, I'll talk about this in a couple of slides. Workforce, this isn't our local figures, but I was just keen again to front up, because I'm really conscious of the ongoing and the immediate issue this is. The scary figures around the number of doctors per thousand population, I think we're probably somewhere in the middle of that. I think we're around 60, early 60s, but we just need to do that across our different CCGs. And the challenges around the workforce, I've been to a number of meetings already when the GPs are saying, look, we're here, Dominic, really enjoying being here, but actually we won't be here in 5 years because of the age and people are going through retirement. So we need to think about what that means and look ahead, as scary as the figures may be, and then agree what we need to do. For me, what this then drives is a conversation about how do practices work. It is not going to be sustainable for practices with the workforce challenges. So we're not going to have the GPs to do everything we need to do, that's clear. So it is then about how do we look across localities, CCGs, neighbourhood areas, in terms of what's that local workforce position, and that's one of the areas I'm keen to get into. This is the sort of local, I've tried to get one on one page. I'm not a big believer in big weighty tomes about which don't mean anything. So this is clearly around what we're trying to do around primary care. So what does primary care strategy mean? I'm keen to bring it to life and start to move in so people are feeling that there's something going on, some momentum around it. There's two main areas. The first one is, which links to the conversation we've had around CQC, is around quality improvement. So what we're embarking on, and there was a meeting yesterday which a number of colleagues went to with CCGs, was in order to improve quality in primary care, we need to be having supportive conversations with practices, and some practices potentially earlier than others in terms of where they are with their own quality challenges. This has been something that's been around, and people have said this is what we're going to do, and I know in previous organisations they've done it and started to do it. We need to go back to that. I'm just a big believer in there's that face-to-face conversation with the right people, with practices, to say how can we support, understand in terms of improving quality. That might be specific quality outcomes, so it might be around your diabetes patients, it might be access, it might be preparing for CQC in terms of the area. I think there's a role that NHS England and the CCGs have, and some of that learning and sharing, I think there's a real big opportunity about, I need to sort of work that through, about how we do that in terms of offering value to all of the practices. So that's one, as you're looking at it, the left. On the right is more around new models and ways of working. So that's where, sort of conceptually, we're saying that's where the workforce discussions need to happen. And also about potential thinking around how practices and general practice looks in the future, in terms of either integration with other services, primary care at scale, again, whatever that means, and that will mean different things in terms of different areas. But what I'm really keen to do, and I did do this technically a bit myself about the CCGs, which I'm very pleased about, is that needs to be at a CCG level. I think where the important thing is around locality. The people think some areas call them localities, some call them neighbourhoods, some call them, but it is about locally, taking your point around different populations demand different things. I'm not fighting that. It is about having a system that is local enough in order to commission better services for your population. And that's through the primary care strategy and CCGs. I'd want to be seeing that coming through really in terms of the different areas. So in East and North Herts, that could be around, there was areas around Stevenage, there's areas around, it's how that all that's played through. We've touched on this, and again, people may have specific questions. Some of the challenges we're facing around capacity, expertise, everyone's very busy. How do we respond to that in terms of general practice? And there has to be benefits of working together. And that could be working together with general practice. It could be working together, the example that I gave, other providers. But what a real key theme that I want to get over is this is about us working together and taking ownership for this ourselves. And it's back to Peter's point around trying to determine our own future. The strategy and everything that's come down for my first sort of 6 months here, we spent a lot of time saying, where's the strategy coming from? The policy says local decision making, local clinicians, so that's what it is. It's back to us. So we've got to make sure that we're in control of that. The skill mix of general practice, and you'll know far more detail than I do, but about in terms of clearly GP challenge, in terms of nurses, primary care nurses, pharmacists, what roles do we want them to have and skills do we want to have them in the future? One of the other areas, responsibilities I have that people have picked up about local professional networks, which is basically we have some clinical time that we have, NHS England has for pharmacy, optometry and dentistry. And one of the key areas that I've said is, well, what view and how do you add value to the primary care strategy? So what is pharmacy going to look like? In terms of optometry, for my days in Leicester, everyone was always moaning about these certain forms that came through and patients got referred to the hospital without the GPs knowing. It's about having some real practical things about new pathways which keeping patients out of hospital. So I'll be really keen to get into some of those conversations. As people will know, I do have an iPad and an iPhone, and there's some great technology in terms of how we sort of work together, how we see patients and how we share information across the system. I know in Watford and the Care Alliance there's a big area about looking around consultations, nursing homes by Skype. So actually having some views and taking consultations, not for all patients, because there will be certain patients clearly that need to be seen face to face, but that's what the GPs are saying in terms of making better use of time. How best can we do that and see patients in different parts of the system through use of technology? Talked about individual sort of populations, so again we need to go back to the basis of that and the investment in primary care. And a clear sort of message is it's how we use that across the system. We have NHS England has some money, but the reality is it's not enough money to meet everyone's demand out there, and also in other practices that we've got across the patch. So it is how we work together to generate the money and prioritise where we spend that money. So I think that's where I want to get into. For people who don't know, Simon Stevens, he's our new chief exec. I think he started sort of similar time to me on the 1st of April. I had the first day off actually, but I think he was at work that 1st of April. And the general direction, which we just talked about, is coming down about integration. So money is coming down to the system. So Better Care Fund is about local authority and health. In terms of the £5 per head, there's opportunities about how we use that across the system. And co-commissioning is around how primary care works with others, are the benefits in terms of, I'll just give some examples, how we commission with pharmacy, flu vaccinations, how we do premises. It's all about working together. So that's the direction, that's the answer. What I'm keen to get the message of is let's work with that and deliver the models that are right for each of your own different areas. I said that I would just touch on really, because this is something that I'm very keen on in terms of my own time, but also my team, and also I'm sure is something with your own sort of capacity. We are all very, very busy. There's a real challenge, I think, if we are agreeing that we need to be more proactive in the way we work, and that's the conversation, some of the conversations I'm having with my team. That is about simply looking ahead and doing work on a daily basis, which is about looking ahead and the future. And I don't know how, probably we're all in the same position. You get home sometimes after weeks or days and you think, hold on, I had my list to do this, I ended up doing that. And I'm sure, and I totally understand from in terms of the operational life of general practice, how that feels. But we have got to make a change. And my sort of sense and mantra is, what I do on a daily basis is my decision. So we determine how we all use our capacity. And that is something, I know there are things that come down and you have to do certain things, but a large proportion is determined what we decide to do. So what I'm keen to do with my team is to get to the point when there's certain things that we stop doing. Because we say, actually, if we do that, that's a day, 2 days a week, and we're not doing this other new thing. And I want to have that conversation. And my sense is, it's as liberating to actually be told, you can not do that, as it is to do the exciting things. And I think we're in control of that ourselves. Otherwise, we'll never have the time to do this. So I think that's something that I'm just really, really passionate about, as you can see, in terms of how we move that on. And it is about us being more proactive in terms of how we work. The capacity and capability, that's all sort of wrapped in what we've said, really. This programme and this development, we need to involve clinicians in that as well, and we have a really important role in doing that. I really do see the importance of managers, being one myself, and in terms of facilitating that change, but we've got to find a way about how do we get the clinical views and influence on the services that we're planning. And that's the real challenge that we have. In terms of style, my own personal style, and what I want to be a local area team, NHS England style. And again, I'll go back to, we are where we are, because I'm sure there'll be some examples that we're not in this way, but want to be facilitative, want to be supportive. Everything we've talked about is about us working together. So I don't want there to be area team, CCG, practices, pharmacists. It is about the benefit is how we work together, and that means different conversations and behaving and trusting each other and working in a different way. And I'm very delivery focused. I'd like to do things at a reason and we actually make some change happen. In terms of some current opportunities, and we'll go on to, Andrew can talk briefly around the CQRS and then happy to have questions. Taking the point about the enhanced services, the emission avoidance DES, I've heard a couple of comments from the system around, oh, this is really difficult and this means that we won't be able to get the money at certain times. I am coming to you with I want to keep that money in primary care. I want to make sure that the money goes out to practices and CCGs, but the services and the elements that are within that enhanced services clearly need to be met. So I want to work with us in the next, however, couple of months to ensure that we're geared up in order to be, because what that's focusing on, back to the coordinated care, is risk stratification, hopefully patients not going into hospital that are now. That's the important bit, and that's the bit we need to sort of go back to. I don't want to get lost in the templates and the various other areas. I want to have something consistent that means that the money comes out to you in primary care for doing the work. So I've got a simple view on that. In terms of the planning guidance, the £5 per head, what I'm thinking sort of in my mind, and we need to share, going to share this in the next sort of week or so, there's something clearly that the admission avoidance DES is about process, as a lot of enhanced services are. What I'm keen to do with the £5 per head is potentially look at outcomes. So there's then, we do all this process, but then it needs to then deliver an outcome. So we would, an expectation would be there will be lower admissions within not a practice level, but we'd perhaps be looking at a CCG, a locality, at whatever geographical area. Money is there, and it's just about how we respond and work together to get it. Premises, in terms of, has focused a lot of my attention in my first month. There are clearly our list of schemes, which are priorities at the minute. Capital is available for the primary care element, but I think there's a real need for us to stop and just sort of consider, given what we want to do moving forward about primary care strategy, where are the priority areas across Hertfordshire and South Midlands for development? There's then the next bit is, well, who do we need to work with and how do we get the money? So there is a real balance here, because there is something about recognising your own practice challenges and making sure that certain practices have their own premises, expanded, improved, and totally understand that. But there is something about how do we move forward in primary care, and what does primary care look like in terms of estate? And that won't mean every practice will be able to have 2 or 3 extra rooms, because that's not, it just the money will not be there in the system. So it's about how, again, we look to localities, different geographical areas, and what do the population need. This was just an opportunity and challenge. Interesting, I had a conversation with public health consultant Kath Fenton earlier in the week around flu vaccination. And that for me, the real benefit within my own team and also across the system is how we join up some of these different pieces of work. My sense of the flu vaccination last year, and I'm sure you'll all understand, was it was far too late, didn't really make the impact we had. So we started talking to pharmacy, I think, about Christmas. What I'm really keen to do is to start those conversations earlier. They're, again, really keen to maintain money in primary care, but we have got target risks of patients which, over the years, we are not getting to. So we then need to think about, is there something more innovative within primary care? That could be GPs, it could be pharmacists. I'm open to those sort of discussions, but I'm keen that we move ahead quicker and we're not doing it too late. It's about being more proactive. So that's, for me, is a big part of the primary care strategy, just a sort of real sort of practical step. I'm not going to talk about CQRS, but my colleague with a tie is, so he's completely, you know, he never normally wears a tie, but he's come today and wore a tie, completely shame me. So I don't know what's the best way of playing it, whether if Andrew does his bit, and then I'm happy to.
Thank you very much indeed. I have to say that Dominic and I understand that we spell the word issue slightly differently, and in the LMC we spell it CRISIS, but when it comes to workload, workforce, premises, and one or two other things, but we'll come to that conversation, I'm sure. Andrew, welcome. Thank you very much for coming this morning.